So we're going to look at the ankle and the foot. The ankle joint proper is made up of the tibia and the talus bone. So that's considered to be the actual joint. Predominantly, again, what we see is a hinge joint. We do see some other motion, sort of like we saw in the knee joint. So it is sort of a little bit more complex than that. And then also in that region, we do have the tibiofibular joint, which isn't a highly movable joint, but is going to be important that we do have some motion in there that allows for proper gait motion. So it's a really dense fibrous connective component between these two bone structures, and as we'll see when we look at this picture, that we do see that the fibula head does go down more inferior than what we see as the tibia. So it provides us a little bit more support and minimizes excessive eversion, which is why we're more capable of performing a plantar flexion ankle sprain. As you can see in the structures, that the tibia is going to articulate with the talus bone, so that's our ankle joint proper, and then the talus articulating with the calcaneus, and that's what most people consider to be your heel joint. So what we see is dorsiflexion and plantar flexion within that sagittal plane. So dorsiflexion is motion of the toes, bringing your foot towards your shin or the anterior tibia. And our major players are going to be the tibialis anterior, extensor digitorum longus, and peroneus tertius. And then when we look at plantar flexion, so that's going to be motion sort of pushing the bottom of your surface of the foot down. And that's going to be predominantly the gastrocsoleus complex, so two large muscles, class 2 lever, and attaches to the Achilles tendon or the calcaneal tendon. And we do have a bunch of muscles, just like we saw in the wrist. So a lot of those muscles that also perform foot motions or toe motions are going to be important in assisting those particular movement patterns. Major external muscles that we see that give us plantar flexion and eversion, as you can see in that lateral compartment, especially fibularis is another term that we use for peroneus. So sometimes you see that written a little bit differently in some of your textbooks. So again, a lot of these motions that we see that take place at the foot predominantly are going to be in the lower leg, and then we just have tendinous insertions in the foot themselves, just like we saw in the wrist, that we have these large retinacula that are going to provide for stability. These are going to be the deeper muscles, as you can see, the fibularis longus, and why it's going to be such a strong everter with the fibularis brevis. Longus just because it attaches to that first toe, your big toe, versus the brevis is going to attach to number 5. Looking from the posterior, you can see that large gastrocnemius, medial and lateral head, and again it's going to converge with the deeper layer that we see here of the soleus muscle as it attaches to the Achilles tendon. So that's much flatter. So what we see is the gastroc crosses the knee joint, is more superficial. The soleus does not cross the knee joint, therefore it has no effect on the knee joint. Other muscles that we see deep in the posterior compartment, again, there's that popliteus that helps to release the knee extension moment. So when we get that screw home effect, when we completely extend our knee, we need something to unscrew that, and that's what that popliteus does. And then you can see the tibialis posterior, sort of a synergist muscle that's going to assist in plantar flexion with the gastrocsoleus complex. Same thing with the flexor digitorum longus and the flexor hallucis longus, hallucis meaning the big toe. Structure of the foot, so that's called the subtalar joint. So below talus, so we're going to see this articulation with the talus and the calcaneus and the the tali bone. That's going to give us the subtalar joint. Then we go down a little bit further. We have the tarsometatarsal and the intermetatarsal joints that, like we saw in the wrist, are going to provide predominantly gliding motions. Then we go down just a little bit further, and then we see the metatarsophalangeal joint. So those are going to be the articulations between where the toes meet the foot, and then the articulation, just like we saw in the hands, the interphalangeal joint. So between the bones that we see in the toes themselves. Again, condyloid and hinge joints in the metatarsophalangeal for the condyloid, hinge joints in the interphalangeal joints. So we do see a little bit different types of motion. So that's why you can actually see abduction, adduction in the metatarsophalangeal joint. So we get some motion in that frontal plane, and then in the interphalangeal, that's why predominantly we just get flexion and extension. So that's going to provide for a smooth transition. So as we look at gait, and we have to go from heel strike to midfoot to forefoot, and then to toe off, all of those motions are going to provide for some relative stability as we go through the joint. And along with that are going to be the importance of these arches. So these arches give us the ability to shock absorb, but also to transition all of those forces as we go through. So we have medial and longitudinal, or excuse me, medial and lateral arches that we see that run longitudinally. So the one that you can see the greatest amount of space under is going to be that medial arch, and they run parallel to each other. And then the transverse arch is going to be formed going perpendicular to those two. Of particular interest is going to be this plantar fascia that will be one of the soft tissue structures that help to maintain that. But what it does is it decreases the amount of energy necessary by the musculature in the transference of maintaining those arch supports, and then during gait it gives us sort of an elastic energy component that's going to allow for a greater transition as we go through gait, specifically in push-off. And this is just looking at the connection to the plantar fascia. So when we look at the complete undersurface of the foot, we do see that there's a large, broad, expansive sheet, and that's actually going to attach to the calcaneus as we move posterior. So there's some soft tissue connection all the way to the calcaneal tendon, or the Achilles tendon. So that's what's known as plantar fasciitis. When people get irritation of that soft tissue structure, typically is going to cause some pain. We have flexion and extension that we see at the toes, very similar that we see in the hand and in the fingers. And then specifically motions that we look at that take place a little bit differently, that are going to be important for gait, are going to be inversion and eversion. So inversion is going to be taking the bottom surface of the foot and sort of motioning it inward, and then eversion is going to be motioning that going outward. So remember that we looked at the distal portion of the fibula and how that projects more inferiorly. So that's going to block eversion, so we actually have more range of motion in inversion than we do in eversion. Just looking at the plantar surface of the foot here, so very similar to what we saw in the hand when it comes to looking at these intrinsic muscles, the lumbricals and some of these interossei muscles that are going to provide for support of the foot structure, as well as some of the motion of the toes.